through the hospital, some from biopsy, and finally they had a surgery. Doctor knows, will tell us more on that. We also have, through our reaches, done about 20,000 people have been touched, men have been touched by our activities in the field and to families. Now, how can we make a difference? Well, it costs about 3,000 naira to screen about one person. So when we want to screen 100 men, we're talking about 300,000 naira. We have to get this cortex evaluation kits from US, and these are what we use to test for the positive or negative of prostate challenges. Now, it means that for 100 men, we need 300,000 naira. And you can choose to support the foundation just for only 10 men. We don't mind, 30,000 naira will suffice. We also look at the people that's only screening. The heavy part of the challenges are when we discover people who are positive. What do? We go to the doctor. It goes all the stages of evaluation until the time for surgery. It costs us a total of 650 to 700,000 naira, 650,000 to 700,000 naira to go through surgery with a patient. But this is not the actual cost. The actual cost is about 1.4 million, 1.5 million. But because we have partner hospitals and clinics where urologists help us to make sure that we get these prices. So if you come through the foundation, you will pay just between 650 and 700,000 naira. So apart from screening costs, we also have the treatment costs. We continue to focus on our screening exercise. We should be able to ask you, both people in the room here and people watching us, to join Thomas John Prostate Foundation in this fight against prostate challenges, especially prostate cancer in Nigeria. It's estimated about 11,000 men die every year in Nigeria due to these prostate challenges. If you want to support us, please, you are free to join us. You can connect us with Tjpf Foundation at org.com. If you go there, you will get the details on how to partner and support us. So we are calling on everybody to please support Thomas John Prostate Foundation, which our founder has left behind for us, and want to grow and make sure that more men are aware, more men are screened early enough, and early detection is the key to prostate foundation.
Thank you, Sir Patrick Ikemefuna. for that inspiring overview. Well, why we wait? Because we need to move to the next speaker, but we will just have to take a little pause. And at this juncture, I'm going to try to remind us of some of our housekeeping rules while we handle the little technical issue that we have at hand. Once again, thank you, Sir Patrick Ikemefuna. Now, the house rules again, just a reminder, this session is being recorded. And for those who are online, if you have questions, please, you can actually type your questions using the Google form. And then for those of us here, the live audience, let's write our questions if we do have questions to ask. And during the question and answer segment, we'll try to answer as many questions as possible. We are going to move to the next speaker, Dr. Ojewola, who is going to take us through everything about prostate cancer, its detection, its treatment, and community support. At this juncture, I will invite Dr. Ojewola to take the floor. Doctor, the floor is yours.
Good morning, ladies and gentlemen. It is my pleasure to be here this morning to talk about one of the topics that is of great interest to me because of the personal experience and the experience with patients that I've had over the years. That a disease that is curable in most patients in Nigeria are not curable because of lack of knowledge and because of lack of awareness. And when I have the opportunity to talk about prostate cancer, I always leave everything behind to address it as much as possible. Perhaps it will help at least one person to survive prostate cancer. Our discussion this morning will be on understanding prostate cancer and what every man and of course family should know. It's not all about men. Men have wives and they have children. And of course, the catastrophic effect of loss of a man affects other members of the family, and that is why other members of the family should also play a role in this advocacy to increase awareness and change the trend, particularly when it comes to survivorship in prostate cancer. My name is Dr. Ojewola. I work with Lagos University Teaching Hospital and also University of Lagos as an associate professor and as a consultant urologist. But before we go into prostate cancer, I think it would be good to lay a good foundation on what cancer is all about. It is important for us to know that every living thing is made up of cells. So cell can be described as the basic unit of life in both plants and animals, human being inclusive. And of course, cell grows and develops from time to time. In human being, there are programmed cell deaths, where cells live for a certain number of days or months and they die off, and it varies from one part of the body to another. But during this process of growth, there may be abnormality in such a way that cell outgrows itself. Usually cells have boundaries. And that is why the cells in the nose will not grow into the eye. The ones in the eye will not grow into the brain. They respect boundaries. But sometimes it happens that we have abnormalities of this growth mechanism, and it makes cells to lose that respect for tissue boundaries, and therefore leaves the organ where it's supposed to be normally, and go to other part of the body, either directly or through blood or through what we call lymphatics. When cell grows abnormally like this, then they form swellings, particularly in what we call solid cancers, like that of the prostate, that of the breast, muscle, brain, and things like that. But it's also important for us to know that cancer can occur in the blood. Those are not solid tumors. We call them leukemias. The prostate cancer belongs to solid tumor because it will develop into swellings that is visible. You can palpate it sometimes or detectable by use of some of the investigations that we talk about. Generally speaking, the goal in cancer management is that we discover it when it is localized. That is, when it is still contained within the organ of origin. As at that time, it is called an early cancer and it is potentially curable. But if not detected at that stage, it escapes into adjacent structures and even distant structures and is considered to be advanced. At that stage, it is no longer curable. And that is the whole essence of advocacy and increasing the awareness so that people will do whatever is necessary to make sure that even if they develop cancer, it is discovered when it is still localized. How serious is cancer issue? It is a public health problem worldwide, not limited to Africa or Nigeria. And cancer is no respecter of persons or age or socio-economic status. It has affected all categories of people and can occur in any body organ. And that is why we talk of cancer in the prostate, in the breast, in the brain, in the intestine, and all other parts of the body. No exception. Cancer of every part of the body can occur. World Health Organization in 2022 recorded 22 million new cases. That is huge. And it is also estimated that there will be increase in the rate of development of cancers per year up till year 2040. As a matter of fact, cancer is the most common cause of death that we have now in the world. So you can see that is a big problem. About 9.7 million cancer deaths occur annually, and total number of people afflicted with cancer that are still alive within 5 years, 43.8 million. I said earlier that cancer can affect every part of the body, but it is more common in some part of the body than the other. Lung cancer, prostate cancer, breast cancer, colorectal cancer are the most common. As you can see in men, prostate occupies an early position there. And of course, notable Nigerians have also died of cancers generally. And many are also survivors. We do not need to mention names. Generally speaking, illness is caused by a combination of factors. These are genetics, environment, and lifestyles. And that is also true for cancer of different parts of the body. Genetics are the genetic makeup, the family inheritance, the racial inheritance. They play an important role. The environment, the weather, and of course, other things in the environment also affects. And finally, how you choose to live your life. As we know, some cancers, particularly lung cancer, not all that suffer from lung cancer are smokers. And of course, it's usually written in the label, even by the manufacturers, that smokers are liable to die young. But despite that inscription, many people are still in the habit of smoking. But it's important that they know the risk that they are exposing themselves to. So now to prostate cancer. I don't know how much we know about prostate cancer. May not be too much, but I believe that this morning we'll get more information that will enlighten us. Before we go into cancer in the prostate, what exactly is this prostate gland? Prostate gland is only found in males. That is why women don't have prostate cancer or prostate problems. It is an accessory male organ of reproduction. And the major function of the prostate gland is to secrete fluids that nourish semen for the purpose of reproduction. So it is doubtful that a man who does not have prostate will reprocreate. So it plays that role in nourishing spermatozoa. Prostate is usually very small, like the size of a walnut. The one thing that is clear, certain, and established is that the size of the prostate increases with age. So, men usually below 40 years, just like Sir Patrick came over and affirmed to earlier, hardly have prostate problems because it's usually small at that stage. It's usually at that around that 40 that it begins to increase in size, and cancer can also occur there. So we'll talk more about that later. Where is it in the body? It is just below the bladder, and it is through it that urine pipe that we call urethra passes through to help in the discharge of urine from the bladder to the outside. It is also in front of the rectum or the anus, and there are a few other organs around that, like seminal vesicle, as we can see in this picture. So that red organ is the prostate that we are talking about, just below the bladder. And that explains why bladder, stores urine. So one of the earliest presentation of patient with prostate problem is to have problems with urination. We will talk more about that later. So, what else do we need to know about prostate cancer? It is the most common cancer in men beyond middle age, 45 years and above. If there are 100 cancers, you can be sure that most of these men, about 45 to 50%, will be prostate cancer. And cancer of other part of the body shares the remaining burden. So, prostate cancer is very, very common. In the past, it used to be very, very rare, below the age of 50. We see it after 50. But things are changing these days. We are beginning to see younger men coming down with prostate cancer. The youngest I've ever treated as a urologist is a 37-year-old man who also has a family issue of prostate cancer. Unfortunately, did not do anything about it until symptoms set in and it was discovered at an advanced stage. Of course, the patient is late now. But what we preach now, because of this downward trend, not only in prostate cancer, there is age migration for most of the cancers, even breast cancer. We see 16-year-old teenager being diagnosed with breast cancer these days. Colon cancer, 18, 19. So things are changing. And that is why this 50 years and above is no longer true. What we preach now is 40 years and above. We also need to know that prostate cancer is more common in black men than men of other races. It is a disease that is very, very common among black men. There are other diseases that are common in whites too. For example, breast cancer is more common among the whites. So for every cancer, there are racial predisposition, which we still talk about. But we should know that generally speaking, prostate cancer is more common in black men worldwide, irrespective of where they are, whether they are in Africa or they are in America or Caribbean or wherever. As long as you are a black man, you have that genetic predisposition to having it. But generally speaking, 1 in 6 men will be diagnosed of prostate cancer. But if you put all the data together, particularly in other parts of the world, only 1 out of 36 will actually die of it. But that figure is not true for us in this environment. The figure is almost like maybe 30 over 36 that will die in our environment, just because we do not understand the concept of screening and early detection of prostate cancer, which is actually the message that we preach rather than prevention. We'll still talk about it. Next slide, please. What then is the cause of prostate cancer? Just like cancer in other parts of the body, there is no known cause. The cause of cancers generally is unknown. But what we have come to realize in science and in medical world is that there are risk factors specific for each cancers. Breast cancer has its own risk factors. Prostate cancer has too. So we'll be talking about risk factors for prostate cancer. Next slide. And we can divide them into major risk factors. That if you have this factor, then you are a candidate that can develop prostate cancer, and therefore the needful has to be done at certain age. And we have some intermediate risk factors, and we have some minor or not yet proven risk factors, but there are few literatures here and there that support association between them and the prostate cancer. The first and the most important is the age. Like I mentioned earlier, you hardly see prostate cancer less than 40 years of age. But at 40, the incidence and the prevalence or occurrence of prostate cancer increases every decade, meaning that at the 5th decade of life, it is more than the 4th decade of life. 6th is more than that of the 5th decade of life, as we can see. As we can see in this slide, the risk is about 23 per 100,000 men when one is between 45 and 49 years. But by the time one is 65 years plus, the risk is almost times 500, 1,000 per 100,000, and that is very, very significant. So age is a risk factor. So what about age? If you are more than 40 years, the risk is already there. The second important major risk factors established by science and researchers all over the world is race, which also talks to genetic predispositions, because there are racial differences in genetics, and that is what gives skin colors and making some diseases more common in certain part of the world than the other. So prostate cancer is almost twice as common in African American men than white men or Chinese men or men of Scandinavian origin. And of course, the second thing to know is that black men, when they develop prostate cancer, are twice likely to die from it than the men of other races. And there are two reasons for this. First of all, the disease in the black men tend to be more aggressive. Racial disposition, genetics, there is nothing anybody can do about that. And the second factor that contributes to increased death rate is because of late presentations. A white man will do the screening annually and regularly. Here we'll be pursuing people. Thomas John Prostate Foundation has been ongoing since 2008. It will surprise you to know that many of the centers where they go, there are men who do not avail themselves of the opportunity to be screened, despite presentations, persuasion, and all forms of encouragement, even though it is at no cost to them. That is the kind of people that we have. So race plays an important role in terms of genetic predisposition, and secondly, our own attitude to healthcare that makes our people present late even when they have the disease. The third important major risk factor is family or heredity. Prostate cancer is one of the cancers that run in the family. There are some cancers that are in some lineages. We have families whose great-grandfather, the grandfather, and himself have cancers documented. I've treated people like that up to like 4 generations. it is likely that the fifth generation will also have it. So they need to be aware of that and do whatever they need to do. Secondly, we also have the second categories of family associations, where about 2, 3, 4 members of a family, where you see about 3 brothers, 4 brothers developing prostate cancer. It is not a coincidence. There must be something in that family that predisposes them to developing prostate cancer. So family history is key and very important. And how important that is related to the degree of relatedness to any member of the family that have it. For example, if the brother in a family has prostate cancer, it is more significant than if it is the cousin that has it or a second cousin. The brother, more important, or the father. Those are direct bloodline, and it is very important. Again, when we have more than one member of a family having it, the risk also increases. That is, if there are 4 brothers in the family, 2 have been diagnosed to have prostate cancer, the remaining 2, the risk that they will have prostate cancer is higher than somebody in another family whose brother do not have such. So the degree of relation and the number of families affected, and as I said earlier, numbers of generations that are also affected, are things that will detect how high the risk is in a family. So these are the 3 major factors. I'll come over them again: age, race, and finally family history. I classify them into 3 categories. The second category is the intermediate risk factors. These are some of the things that have come to the fore in recent time that affects the occurrence of prostate cancer in a population. One of them is high intake of red and processed meat. How do we come about this? A lot of studies have shown that prostate cancer in Chinese men that are living in America is higher than Chinese men living in China. Chinese men anywhere, just like I talked about black men anywhere, they have the same genetic composition, whether they live in China or they live in America. But they found out that the cancer in Chinese men in America is slightly higher than those of Chinese men living in China. So what could be responsible for this is probably environmental factor or lifestyle, like the eating habit. And it's been discovered that high intake of red and processed meat, dairy products, and some vegetable oils that are rich in certain acid, that mainly fatty acid, has been found to increase slightly the development of prostate cancer. So what you eat also has a role to play, although not as major as those 3 factors that we discussed earlier. These are some of the things. I won't go into details of the fruit and vegetable, tomatoes and tomato-based products with various vegetable, omega-3 fatty, soy and legumes, green teas. These are some of the things that have been found to offer some protective effect against prostate cancer. But again, I said, they are not major risk factors. Next. Others that have been queried are smoking. Little relationship between smoking and prostate cancer. It's not like that of lung cancer, that we know smoking leads to lung cancer. In prostate, the result has not been consistent. We have also heard about excessive vitamin A, and of course when vitamin D are deficient. These are some of the things, but they are not as major as the ones that we mentioned earlier. Next slide. I'll just go through this, and I think this is one of the most important slides. There are a lot of erroneous belief about the cause of prostate cancer. Why some believe it's an attack, some believe it is spiritual, and some believe in a number of other things as the responsible factor that predispose a man to developing it. Inadequate sexual intercourse or inadequate numbers of ejaculation I saw a video trending at a time that a man has to ejaculate like 21 times in a month or so in order to prevent prostate cancer. It is a lie. There is no fact in that at all. Whether inadequate sexual intercourse or excessive sexual intercourse or ejaculations, none has a bearing with development of prostate cancer or celibacy or sexual abstinence, even sexually transmitted diseases or vasectomy for contraception or marrying one wife or marrying many wives. All this, science has not proven a cause and effect relationship between all these factors and development of prostate cancer. So they are not true. The ones that science has established are the ones that we mentioned earlier. How do I know that, prostate cancer is coming up? And that will lead us to discuss symptoms of prostate cancer. But the first thing we need to know is that prostate cancer may be present and yet there are no symptoms at all. As a matter of fact, this is typical of most cancers in the body. Most cancers, when they first start, they do not manifest with symptoms. By the time symptoms are coming on, it is telling you that the cancer is establishing itself and is becoming advanced. So many times there are no symptoms. Unfortunately, there are other times that symptoms are there that we can call warning signs, but they are not recognized. Or sometimes when they are there, they are ignored. Ignoring symptoms is one of the commonest problems that we have in our environment. And of course, many just commonize the presence of some symptoms that they are part of aging process. Whether waking up like many times at night, that is part of aging, and they just commonize it and they do not go for medical help. So cancer at the beginning usually do not come with any symptoms. It's when it has progressed to some extent, then it begins to manifest with symptoms. Next. The most common problems that patients with prostate cancer present with is with urination. And the reason is because of this anatomical explanation that I offered earlier. If you look at that picture, you can see the bladder, urine in the bladder, and it's flowing through the prostate in that direction outside. Usually, if there is no other reason for blockage, urine flows very well in younger men. But by the time the prostate begins to increase in size, the tube runs through the prostate, it is compressed, and you can see we begin to have obstruction to the flow of urine, and we can begin to have retention, urine going back, and that can lead to a wide range of other symptoms. But the earliest symptoms that men with prostate cancer usually have are related to passing urine. And what are these symptoms? Urinary frequency, waking up, passing urine more times than usual. Like in a day, more than 5 times, at night, more than 2 times, or nocturia, more than 2 times. I've seen patients that said he wakes up as many as 15 times at night before. And of course, there may be urgency, that is, inability to postpone the act of passing urine. That whatever you are doing, no matter how important it is, you have to leave whatever you are doing, even if you are eating, even if you are praying, to go to the toilet. Or hesitancy, where the urine will not come out immediately, or the urine comes out but it's very slow, or just dropping, trickling out. Or a situation when a man starts to urinate and the urine stops in the middle and starts again on and off like that till the end. Or when the man has left the toilet, he still continues to have the feeling that urine is left in the bladder. That is what we call feeling of incomplete emptying of bladder. These are the earliest and the most common symptoms that men that have prostate cancer will have. However, it is not only prostate cancer that can give this. Anything that will lead to increase in size of the prostate will cause that. We also have another disease that we call benign prostatic enlargement. That is the enlargement that comes with aging. It increases. As a man develops baldness or develop gray hair, the prostate begins to increase in size and it can happen. But it is not cancerous, but it's also a major cause of the symptoms of obstruction to the flow of urine. So one may need to see a doctor to be able to differentiate between the two. But the presence of that symptoms means that one should seek clarification to be sure it is part of the aging process caused by BPH and not by cancer of the prostate. And of course, infection in the prostate and in the urine can also lead to some of these symptoms. Those are the early symptoms. Unfortunately, many people that have those symptoms will not seek help on time. They will wait. And by the time these symptoms continue, cancer continues to grow and now affect structures around. And a man can now begin to have blood in the urine if it has affected the bladder, or blood in the semen if it's affected another organ we call seminal vesicle, or even blood in the stool if it has gone to the rectum. If it has spread to the back, can have low back pain. If it has involved the nerves, the spinal cord, it can lead to weakness or even paralysis of the legs. That is very common here. And of course, if it spreads to any bone, it can cause bone pain. As a matter of fact, spread to the bone is one of the major manifestations of prostate cancer that we see in this environment. And that is why we usually want to investigate them for bone spread when they come. And of course, lack of appetite, significant weight loss, body weakness, and of course, if it has spread to the brain, they can have persistent headache and they can have, even fit or convulsion. What do we do when patients come with any of these symptoms, or when they walk up to us that they want to screen for prostate diseases? We do a digital rectal examination, which is an examination where a doctor puts the digit, the finger, into the anus, into the rectum, and feels the prostate. We usually want to look for whether it is regular or irregular. Irregularity means it may be cancer. Whether it is smooth or rough, roughness means it may be cancer. Whether it is enlarged asymmetrically with one side bigger than the other. These are some of the things that can give the doctor an idea that the patient may be having prostate cancer. Secondly, blood test that we call PSA can also be done to screen, to differentiate between whether it is BPH, natural aging process, or cancer. 10 minutes more. Okay. All right. And of course, prostate scan. And if we combine the information we get on digital rectal examination, prostate-specific antigen, and prostate ultrasound or MRI, we can decide to do a biopsy when the suspicion is high from any of those three. And in biopsy, what we do is to introduce a needle through the anus to get to the prostate, take samples or prostate samples, which we subject to analysis in the laboratory, and the confirmatory result that it is either cancerous or not cancerous comes. Next slide, please. So if the prostate biopsy result comes out and it is cancerous, there are other tests we normally want to do. MRI, magnetic resonance imaging of the prostate and the pelvis, just to see the extent of the cancer. Has it spread or still contained within the prostate? And that has therapeutic implication as to what is the appropriate treatment that we need to give to this person. And of course, I mentioned earlier, it can spread to the bone scan. And of course, these days we now have PET scan also available in Nigeria. Next slide. So this is just to possible level of diagnosis of prostate cancer. You can see that red part is the prostate gland. If the tumor is inside, like you see lower down there, you will say that it is localized. But you can see the second yellow circle is almost escaping the prostate. So at this stage, we say it's locoregional because it's still confined. And of course, as you see on the right-hand side, it can go through the lymph node or bone to distant structures like the brain, like the liver, that are not even in the immediate vicinity of the prostate. Next slide. These are stages 1 to 4. 1 is very early, 4 is very late. Next slide. And of course, stages 1 and 2 are the best, and that is the target. And that is the whole essence of all this effort. That if one is to have prostate cancer, let it be diagnosed as stages 1 and 2. And the reason is because treatment at this stage is curative. And we have many men whose case were discovered at this stage, received treatment, 10 years, 15 years, 20 years, they're still alive. And by the time it is stage 3 and 4, you cannot cure the cancer at that time. You can only offer some palliative treatment that will last them for some years, only God knows. So, the whole aim of whatever we are doing here is to be sure, to make sure that men are detected when their cancers are still early. I won't go into details of this, but these are just treatment. If it is stage 1, surgery or radiotherapy. Next slide. If it is stage 3 and 4, we cannot cure. What we do is just to manipulate the hormones, because prostate cancer feeds on hormones, male hormones, and the male hormone comes from the testicles. So at that point, it's either we remove the testicles to deprive the cancer cells of the hormone, or we give some other drugs, as you can see there, that drive down the level of male hormones in the men, so that the prostate cancer will not continue to grow. What are the reasons for high death rate in our environment? Late detection. And I mentioned earlier, our disease in Africans are blacks, are aggressive. Unfortunately, too, many men also fall victims of fake doctors who do not know what to do, and they are treated wrongly. And some, the diagnosis was gotten, but they got inadequate treatment for financial reasons, because they cannot afford what was offered to them. And of course, there are some that just do not comply with this. So, what will be our strategy? The strategy is to survive prostate cancer. We look at two things. First is, can we prevent prostate cancer? If we can prevent it, can we direct all our efforts to preventing it? But the answer is, it is not totally preventable. And why is it not totally preventable? Remember, all those major risk factors that predispose a man to developing prostate cancer are not modifiable. First of all, you cannot change your age. Even if you falsify paper and you are a 50-year-old man and you say you are a 30-year-old man, the biological clock is ticking. It recognizes you as a 50-year-old man. The risk is there. Secondly, we talk about race. Even as a black man, if you bleach your skin and you become white, you remain a black man. The blood flowing through you is still that of a black man. And finally, the same family. You can change your name from local name to English name or whatever. It does not change the fact that you are a member of that family. So if the risk exists in that family, it follows you. So you can see all the major factors are not modifiable. You can't do anything about them. The only one you can do something about is to eat right, as we mentioned earlier. So if we cannot prevent this largely, what do we focus on? Early detection. And that is the key. And that is the message that we pass across. And that is one of the aims and objectives of Thomas John Prostate Cancer Foundation. How helpful is early detection? It's been found from researches all over the world. Localized and early detection, survival rate 5 years, 10 years is as much as 99% if appropriate treatment is undertaken. But for late disease, it's only 31% that will be alive at 5 years. It's even worse in our environment here. Next slide. So what should you wait for? Are there warning signs? I told you earlier, there may not be any symptom. Even if present, symptoms are not specific to cancer of the prostate. They can be caused by other things. Therefore, testing, routine check is the key to detecting it in the body. If you are at risk, you are more than 40 years, you are a black man, you come from a family that have positive history of prostate cancer, those are key risk factors, then this is for you. You have to go for screening. And the screening entails doing a blood test, PSA, doing a digital rectal examination, which is usually conducted by doctors, By the special grace of God, that is my own contribution to Thomas John Prostate Foundation, because when they screen them and they do PSA, they send them to me. I complimentarily do their digital rate examination and decide whether they will need a biopsy or not. And of course, ultrasound is everywhere now. So who is to undertake screening? I've said this and cannot be overflowed. All men above 40 years. If you are less than 40 years and there is positive family history, your own screening must start earlier. I told you the youngest I've ever treated is a 37-year-old. How frequently should this be done? Annually. Who are you to see? It's better you see a specialist. It may be a bit more expensive than seeing a general medical practitioner, but they are more knowledgeable. This is some things about PSA. In the medical world, we call PSA prostate-specific antigen, but some of us coined it as providentially sent antigen. That is an antigen that God opened the eyes of science to detect in the blood in order to help us. Because for most men, their PSA is the first thing that we give an idea that prostate cancer is in their system. And that is why we should not screen with it. And I give kudos to Thomas John Foundation because they started with qualitative screening. And of course, they send them to me. I send them to the lab. They do quantitative. And through this, we have been able to diagnose so many, courtesy of Thomas John Prostate Foundation. So, if it is elevated by any standard, it should be investigated. It should not be ignored. So this is the digital rectal examination that I mentioned earlier: smoothness, regularity, symmetry. And we do this as a complementary test to the PSA. We do not interpret PSA alone. We had all the information we get from PSA, from scan, and from this examination to make up our mind. And so I will just continue. Imaging. So these are the tests we sometimes send these our patients to go and do: abdominopelvic ultrasound, transrectal ultrasound of the prostate, and of course MRI. And I can tell you that Thomas John Prostate Foundation has sponsored all of this for many of the patients that have come through me before, including MRI, which presently is about 150,000 naira, even in Nigeria. A round of applause for Thomas John Foundation. So how do we avoid an advanced diagnosis? Early detection. And how is early detection possible? Through screening. So men in the house, either physically or online, we have to wake up from our slumber and we have to assume responsibility for our health. So what if doctor does not talk about PSA or DRE for you? You have the right to demand to be screened, to be tested. If you are above 40 and you have never done a PSA, let this be a wake-up call for you to go for your PSA. Please insist on being tested. So be a man, take responsibility. Normal PSA value is between 0 and 4. So don't let doctors or anybody tells you your PSA is fine. Please know your number. Normally it's supposed to be between 0 and 4. And document it appropriately, because it is not the figure alone that matters. The rate of increase year after year is also important. For example, if in the year 2024 someone has a PSA of 1.5 and a year after has a PSA of 3.8, even though both figures are still within normal limits, but that person should be investigated for that high jump in the level of the PSA. So don't accept any doctor telling you your PSA is fine. No. So if your PSA is high, say a urologist, he will do a DRE, he will order some scan and rule out other things that could be responsible for high PSA. Infection can lead to high PSA. Even after doctor's examination, PSA can be high. And infection in the urine and in the prostate can also lead to that. These are some of the things that the urologist will be able to tell you. And if it is infection, antibiotic treatment will suffice and drive your PSA back to what it is. So in case you have been diagnosed to have with a prostate biopsy and they say the cancer is, the biopsy result is positive, please don't panic. Learn your treatment option by contacting a urologist. If necessary, you can get a second opinion from an unbiased person, and of course, do all the other things that are necessary. Aside from talking to men, other members of the family also have a role to play. If you are a wife and your husband is more than 40 years and has never been tested, please ask them to go for a test. If you have parents or uncles who are of that age and has not been tested, and other loved one, relations, and people that you are at work together, you won't lose anything for talking about PSA with them, and that may be the wake-up call that will make them to be tested and possibly to be detected early. In summary, prostate cancer is not totally preventable, and the risk factors, as I told you, are not modifiable. There are some drugs out there that can reduce the development of these, cancer, but they are not very, very effective. And these are some of the things. What can I hit? Let's go. So early detection is to go routine prostate check without having symptoms of a disease. It helps us to identify it earlier, prevent complications, and makes a whole lot of difference in the outcome of the disease. Unfortunately, in our environment, we have very poor attitude to screening. In conclusion, prostate cancer is real and very common, actually as the most common cancer in men beyond middle age. As emphasized during the lecture, it is not totally preventable. Early detection is, however, possible with screening before symptoms begin to set in. And the advantage of early screening is early detection and possible cure, even if cancer is diagnosed. Our health is our responsibilities. Many of us as men chase monies and other things. In fact, we prefer to spend money on our children and on our wives, and we neglect ourselves. I think we should take ourselves serious and take our destinies into our hands regarding some of these problems. I think I've come to the end of the lecture. We'll just wait for question and answer. But this lecture is dedicated to late Sir Dr. Thomas M. Asuquo John, the founder of Thomas John Prostate Cancer Foundation, who spent substantial part of his life helping men who were already diagnosed and also advocating for early screening, and has helped thousands, as Sir Patrick Ikemofena affirmed to earlier. So thank you. I'll wait for questions and comments.
Ladies and gentlemen, please let's give Dr. Ojewola another round of applause for that insightful presentation. I must say that this is the first time I'm actually getting a very in-depth presentation on prostate cancer. And maybe I'm one of those you've just convinced to be doing this every year. Well, I think I will have to start doing this. Well, thank you once again, Dr. Ojewola. We have some questions. Some came earlier, and then we have, let me start with the one we have here that came in from the live audience, and then we can move on. This question focuses on the relationship between HPV and prostate cancer. It says, if a female has breast cancer in the family, is there a relationship to the male family, to the males in the family, like brothers and grandchildren, and will they be at the risk of prostate cancer?
There has not been any relationship between development of prostate cancer in a person whose female family members has cervical cancer or even breast cancer. But for sure, we know for prostate cancer, particularly men in that family, if any one of them has prostate cancer, the risk is higher for other men of male members of that family. But in terms of breast cancer and cervical cancer in women in that family affecting the prospect or the development of prostate cancer, science has not established that. It's not one of the risk factors, and you can see it's not part of what I discussed as a risk factor for developing prostate cancer.
All right, thank you, Doctor. Let me take one that was sent in while you were presenting. It says, I am 41, but have had BPH since I was around 35, 36 years. During the year when I went for annual PSA test, it showed I have elevated PSA of 9. Did retests after several weeks with PSA of 11 and 10. The doctor performed digital rectal examination and I was cleared fine. Subsequently, did another MRI scan, second in 3 years, no cancer found. There is worry because of the elevated PSA. Must I do a biopsy? Do I necessarily need a biopsy considering the likely side effects?
Yeah, thank you very much for that question. 41-year-old with a PSA of 9 and at another time PSA of 11. That is a high risk for presence of cancer in the prostate. As I mentioned earlier, it is not only prostate cancer that cause elevated PSA. Infections in the prostate can cause it, and even ordinary benign prostatic hyperplasia can cause it. However, cancer is one of the causes, and it is important that we detect the presence of the cancer in that prostate before it goes haywire, before it metastasizes. There are 3 indications why we recommend prostate cancer. First, once PSA is beyond the boundary, irrespective of what the doctor's digital rectal examination is and what the MRI says, we have to explain that increase in the PSA. It is better we do a biopsy, confirm that it is not cancer we are dealing with and is the other, than to assume that it is not cancer. From 9 to 11, it could be 15. That tells you that if it is cancer, it means that it's establishing itself and growing. For the person that has the question, 41-year-old PSA of 9 is high. In fact, at 41, the ideal PSA is about 2.5, not even 4. So if it has that 9, irrespective of what the MRI says and what the doctor found on digital examination, it deserves to have a biopsy. Biopsy is very, very safe. I have done biopsies for patients from Thomas John Foundation too. I don't think even, Sir Ekimofon, I remember now, I'd even forgotten. I've done a biopsy for him. And I don't think there is any significant side effect. The truth of the matter is that there is nothing without risk in life. But many times the benefit outweighs the risk. Once the benefit outweighs the risk, then the risk is worth taking. Biopsy is very safe if performed very well. Infection is one of the most common complications that we see with biopsy. But if you prepare your patient very well, it is not likely that infection will happen. So I will suggest that that person, to be certain and be sure, it is better he has prostate biopsy conducted. If now conducted and it comes back, if it is infection, antibiotics, and there are also drugs that can, with PSA of 9, and have a biopsy as per protocol, both locally and guidelines across the world.
Okay, thank you, Doctor. In line with that, I'm going to read out 2 questions relating to the treatment, and then you can take the 2 together. The first says, many patients fear treatment side effects. Can you discuss how modern treatments minimize complications? That's one. Then the second one is, how does a patient know whether surgery, radiation, or active surveillance is the best option?
All right. So thank you very much. As I told you, prostate cancer is curable when it is in stage 1 or stage 2. And the treatment options for that stage is either to do surgery or to do radiotherapy. Either surgery, they have their side effects. There is nothing, as I said earlier, without side effects. The side effect of surgery essentially are weak erection or loss of erection and leakage of urine that we call urinary incontinence. Those are the 2 main worry or concerns that patients usually have. Technology has actually advanced In the past, all surgeries for prostate cancer in Nigeria had to be open. You have to cut the patient down and get to where the prostate is and remove it. But even in Nigeria, technology has advanced that prostate can now be removed laparoscopically. And more recently, there is introduction of robotics into our practice in Nigeria, that prostate removal can be undertaken by the aid of robots. With robot and with laparoscopy and newer technique in removing, there is what we call nerve sparing technique. There is a nerve called cavernous nerve that goes around the prostate, and that is usually what is damaged when prostate is removed for cancer. But technology has developed to the level that you can identify them during surgery, put them apart, and that has gone a long way to reduce the risk of erectile dysfunction following that. And even for those that have it, many of them recovers with time. Recovery time differs in patient. It may be 3 months, maybe 6 months, maybe 18 months, or 2 years. Yes, some never had it, but there are other ways we treat. There are tablets we give them to help, and in the most extreme of cases, we can put implant in the penis, and they will still be able to achieve erection. The second question is about which one is more appropriate. That is the job of a urologist, and most times it is a shared decision. The truth of the matter is that the urologist will not pick for you whether to do surgery or to do radiotherapy. It depends on you, but we usually walk them through that process. And I will give you 2 examples of extremes of patients that I've seen. There are some patients that even if their cancer is at stage 1, and you assure them that when you go and remove it by operation, they will be cured of that cancer. But the moment you mention that is going to affect their erection, not even the operation, some men will run away. You will never see them. And we've seen some reasonable men too that will tell you at age 60, I have children. I've been doing this thing for 30, 40 years or whatever. Let me live first. Even if I'm going to have erectile dysfunction, I do not care. I want to be alive to enjoy the investment I've made in my life. Those are 2 extremes. For the first patient, no matter what you do, he will not choose surgery. For the second patient, who has that kind of mindset, he can easily go for surgery. So we need to interact, discuss this. How much do you follow sexual intercourse? Can you do without it? If in case this happens, that is one of the major factors that will determine whether they go for radiation or they go for surgery. So it's a shared decision. But as doctors, we walk them through and let them know these are your options. Eventually, they should. There are some that want to have surgery and they don't have money for the surgery. They truly will have loved to have the prostate cancer removed out of their body, but they don't have the resources to do a major prostate surgery, maybe 2 million, 2.5 million. If you want to do it laparoscopically, we'll be talking about 18 million. If you want to do it robotically, we'll be talking about 30 million. So some people really want to have it done, but there is no means. So they will definitely have to choose other options by the constraint phase financially. So those are part of the factors that determine what a patient eventually picks.
Okay, doctor.
Thank you.
Thank you. 2 more questions came in, and I will take those. Said, how do clinicians balance early detection of prostate cancer with the risk of overdiagnosis and overtreatment, especially in low-risk patients? That's the first question. Maybe let me just give the 2 so that you will take them at the same time. All right. The second one says, thank you, doctor. Please, is there specific food recommended to keep a healthy lifestyle or keep low chances? I think this aligns with one of the questions that we had before that talked about dieting. I think you mentioned something like that. So maybe just for balance, harmonize everything. How does the diet help with the whole prostate cancer health?
All right, thank you. The first question is about overdiagnosis.
And over treatment.
It is actually a problem that we encounter because we have discovered that there are some cancers that actually, yes, they have cancer, but they may be there without causing any havoc for many years. And that is why biopsy should be performed, because it is the biopsy that will give you this information that we need. For example, we have what we call Gleason grade and Gleason score. These are scores that pathologists give us in their report to tell us about the aggressiveness of the cancer. We will see some people will be diagnosed to have cancer today. In 1 year, they are no more. And we have some people who have had this diagnosis for 10 years and they've not done anything about that, and they are still alive. The difference is in the aggressiveness, which is what we call Gleason score. So pathologists usually help us with that. The lowest of the score is 6 and the highest is 10. Any disease where the cancer is said to be aggressive, 10, 9, 8, even 7, they should be treated well. You cannot over-treat that because it's a matter of time they will progress. But the ones at the lower end of the ladder or the spectrum, Gleason 6, those are patients that even though we know that they have prostate cancer, they are people we can observe, watch, and do what we call active surveillance, where you ask them to report to you every 3 months with a new PSA, with a new imaging, with your own examination. And you only treat them when there is evidence that the cancer has progressed. What are these evidences? First of all, you may need to repeat the biopsy after like 2 years to see that a cancer that is not aggressive today has not changed its biological behavior. If you do it 2 years after and it tells you that the cancer remains the same, there is no need to treat that. But if after 2 years the biological behavior of the cancer has changed from 6 to now 8, 9, or 10, then you can no longer fold your hands in that kind of patient. You have to offer him something, and you move from active surveillance to actual treatment, either radiotherapy or surgery. So over-treatment is a concept, and many of us have actually treated that we should not treat before, but we understand it better now, that there are some categories of people that are fit when they meet the laid down criteria for you to observe them and follow them up and not rush to treat them. I'll give you another example. If we have a 90-year-old man who does not really have any symptoms, but maybe Thomas John Prostate Foundation goes to their church and he offers that he wants to be tested, and we now discover that the PSA is about 18, 19, or 20. In that categories of patient, what we do is individualized. If that man, 90-year-old man, has many other comorbidities, is hypertensive, has suffered from stroke, has diabetes and things like that, there is no point even going for the evaluation, because the prostate cancer, even if it's developed at that time, will probably not kill him as fast as any of those ones that I mentioned. But if you see a 90-year-old man, even though he's 90-year-old, but is active, does not have any of this comorbidity, he wants to live for another 10 years, we can take it further and screen, and whatever result we get, determine. That comes to the concept of another category that we call watchful waiting. So in this category, we don't want to do any major thing like operation for them, 90-year-old, no, or even radiotherapy. But we monitor them. And when we have to give them treatment, we just give them some of the treatment that are for palliation. And that is when hormone treatment comes in, or removal of the testes to slow down the rate of production of the androgen that feed the cancer cell and make it spread. So it is real, and it is something that in the medical cycle we are also aware of, and we try as much as possible not to. So, and that is the origin of the active surveillance. That yes, it's prostate cancer diagnosed, but from literature and experiences here and there, even if you don't do anything immediately, nothing is going to happen. So we give them that opportunity and monitor them. It is particularly important for younger men. Let's assume that we have a 48-year-old man diagnosed to have prostate cancer. If it is not a very aggressive disease, we may not operate that kind of a patient. For example, if he has not completed his family cycle, maybe he's not married yet, and I've seen patients like that. In fact, I remember this foundation has sent a patient like that to me at some point. Has not even married when this happened. So going to do prostatectomy that will take erection and the possibility of fathering a child away is not appropriate. We can actually wait a bit, give him time to do whatever he wants to do if it is not a very aggressive disease. If it is an aggressive disease, we may not do surgery, we may do other things that will also give him the opportunity of completing his family cycle. Thank you.
All right, last question from me, and then after this answering this question, you can give your final advice so that we can call it a day. The question says, what support systems should patients and families look for during treatment?
Thank you very much. Unfortunately, we don't have so much support system in our clients here. But elsewhere, there are support systems that are available. These include every hospital having a support system for patients that are being treated for a particular disease. We are beginning to do that in Nigeria too. Secondly, organizations and like that of Thomas John Foundation are part of the support that patients who are being treated for prostate cancer, not only for sponsorship of their treatment, but also for education on the cause of their treatment. Elsewhere, we also have cohorts of men who are suffering from prostate cancer, who have a group where newly diagnosed men can interface with them and they share the journey of their life. By the time a patient who is newly diagnosed to have prostate cancer today meets another man who tells him that I have this diagnosis for 15 years, 20 years, that itself will give him some succor. Because every person diagnosed with cancer have this idea that he's going to die the next day or the next month. But when you learn from practical examples and people speaking, not theory, not even doctors talking about others, but people are talking about themselves to newly diagnosed people, it goes a long way. Some of these support systems are not available locally. It is because of who we are. We may be neighbors. I'm passing through something. I don't want him to know that I'm suffering from prostate cancer. Unlike elsewhere, like Prince Charles now in the UK, we all know that is King Charles is a prostate cancer patient. And when he was undergoing treatment, it was on their national television, everybody knows. Our own leaders, when they have that, we don't even get to know that they have that, not to talk of the treatment that they underwent. Those are part of the things that have to change in our system to encourage patients suffering from this disease. And finally, support from government cannot be overemphasized. Treatment of cancers generally, including prostate cancer, should be part of national health insurance scheme, should be covered. At present, I am not sure many of these cancers are covered. So even if a patient who wants to get a treatment is not able to get it because of the depth of his pocket, if it is available and there are some percentage relief that he will get from such a scheme from government, I think it will go a long way. But I also want to say that we need more of Thomas John Prostate Foundation. Thomas John, just like he told us, in his lifetime had prostate cancer, but he was lucky, it was discovered early. And that was why, being the kind of person that he was, felt that I was lucky to have this and to have survived it. I want to help men. We need more men like that. I can tell you, many of our big men are suffering from prostate cancers and they have treated it in one way or the other. But what are they doing with the grace that God gave them to be a survivor? So we need more men, we need more foundation to support these people. And treatment of cancer generally is not cheap. That is the truth. And that is why we need this kind of support, particularly in our environment where treatment is out of pocket. It's not by any NHS or whatever. It's out of pocket spending. There are many who truly want to receive treatment, but they could not afford it. So all of this support system, financially, advocacy group, patient support system, even from patients who have suffered from prostate cancer, will go a long way to help patients who are newly diagnosed and who are still on treatment for prostate cancer.
Thank you, Dr. Ojewala. Final word from Sir Ikemefuna.
Thank you very much, Doctor. That was also illuminating, and some issues were very new to me. Now we can see from Dr. Ojewola how serious this situation is. So I kept this so that you can see, you can hear. How do you now support Thomas John Prostate Foundation? In this our journey, we need partners, we need assistance, and we need more people, more laborers in the vineyard, if the way we say it. We are looking for laborers. So not only monetary aspect, you can provide services, you can decide to help us in some structures we have staff that are running around the whole place carrying out outreaches. So if you want to support us, please, we have Thomas John Prostate Foundation. We have an account with Fidelity Bank, account number 502-009-2100. Again, Naira account 502-009-2100. Our domiciliary account in dollars, also Fidelity Bank, is 509-007-1029. Again, domiciliary account in USD, 509-007-1029. To do our work. We thank all of you, especially Dr. Ojewola, Associate Professor. So probably next time he will be coming up, he might be a full professor. He has been with us for almost the 15 years on this track. So we have seen him from a doctor, and he has gone up to become an associate professor, and he's been working with us. Very humble, very easygoing. So thank you very much, Dr. Ojewola. And for everybody here, on behalf of Thomas John Prostate Foundation, and the staffs here. We thank you for being present both in the room here and in the webinar, being part of it. I know there are many people already putting all this. And for these questions, they are very, very insightful, and we appreciate the answers we have got from Dr. Ojewola. Thank you. Thank you, moderator, and then the organizers.
Thank you very much, Sir Ikemefuna, Dr. Ojewola. Thank you very much. Sir Ikemefuna has done the vote of thanks, so I will take that as the vote of thanks. For everyone, my final word is, let's take care of our health. It's very important because, as the saying goes, health is wealth. Thank you and have a nice day.
Thank you. No, it's okay. We'll manage it.
Oh,
Yeah.
that reminds me, please. We're going to have a photo section outside, so please let's all just go outside right now for the photo session.